We'll get started, and welcome to Workshop 11, Combining Nursing and Physiotherapy Services to Treat Bladder Health in Our Older Adult Population. And I know as allied health professionals, we're usually at the forefront of patient care. We're on the ground. We're often the first person that the patient visits, and we're always working together as allied health in conservative, holistic approaches. So I know it's not good to sandbox ourselves. I work very closely with my pelvic floor physiotherapy, and I'm sure we all liaise with our allied health workers. So this is about combining those services. My name is Frankie Bates, and I'll be chairing this workshop today. I'm a nurse continence advisor from New Brunswick, which is the east coast of Canada, and I manage a urology wellness clinic. I treat LUTS in men, women, and children, as well as erectile dysfunction. And I have no disclosures. I'd like to welcome my panel here today. First of all, we have Heather Moki. Heather is a pelvic floor physical therapist and has been for almost 20 years in Chicago. She is currently at the University of Illinois Hospital, as an outpatient physical therapist, and she's also an adjunct faculty for the university for the last 8 years. So welcome, Heather. And a big thank you to Angie. As you may see, we've had a change in speakers at the last minute, and Angie very kindly stepped in and saved the day. Angie Rantel has been a women's health nurse for 15 years and is a lead nurse for urogynecology at King's College Hospital in London. So welcome to the panel and welcome everybody, and we'll get started and hopefully we'll be on time. So let's start with the definition of urinary incontinence, and this is according to the International Continence Society, that urinary incontinence is the involuntary loss of urine. Now, when we look at prevalence, there's always been a measurability problem that surrounds incontinence, because it's not so much a quantitative problem or how much your patients leak, but a qualitative problem or how much it affects their quality of life. So it's very difficult to measure and define. It affects 423 million individuals globally, and we know that's a grave underestimation of the true numbers because many of our patients will suffer in silence due to the taboo nature of the topic. In Canada, it costs an estimated $2.6 billion a year. This is from the direct costs, which are $1 billion, and this is from falls directly related to UTI, and there's a twofold increase in the incidence of falls and a 30% decline in functional disability that's directly linked to urinary incontinence. The costs of urine tract infections, of pressure ulcers, and also the costs of hospitalization, both to acute care and long-term settings, are all a factor. And then we look at the indirect costs, which were staggeringly higher in Canada. This was from loss of productivity in the workplace and from absenteeism in the workplace, and loss of productivity at home, and also depression from the isolation that incontinence usually occurs in. When we look at geographically, we can see globally it's between 8 and 9%, similar in North America to Europe, and strangely enough, the lowest incidence is seen in Africa at 7.2%. But we probably don't know if this is a true number or if it's from lack of, I don't know why that keeps flicking there. Lack of patients presenting and inadequate clinicians and expertise and lack of diagnosis in this area. So the impact of urinary incontinence on our older adults is profound. It affects both morbidity and mortality. It affects sleep deprivation, and this is in a group of adults that are already sleep deprived. And then you put in the mix that they've got to get up at night, get themselves into the bathroom, sometimes have to change themselves and try to get back to sleep. And they'll have nocturia often 2 or 3, 4 times as in our older adult population. So it's significant for them the next day. As I mentioned, the incidence of falls is very important, and sexual function, something we don't typically concern ourselves about with our older adult population. But we're seeing more and more couples live to longevity. We're seeing more millennials live to an older age, and they want to be intimate. They want to have sexual activity, and they won't tend to do that if they're leaking urine. Incontinence affects depression and leads to isolation and social withdrawal. And I think we've all seen our patients, how they change, how they dress in dark, baggy clothes so they can't be discovered, and they stop socializing at events where they may be discovered, dancing or walking or playing cards or playing bingo. So they tend to socially withdraw from these activities. Incontinence also increases the incidence of urine tract infections. And in our older adult population, this is really important because they don't tend to have the same symptoms that their younger counterpart would do. Like we have dysuria, increased urgency and frequency. Not sure why those slides keep going forward. But in our older adult population, what you're going to see more of is mental confusion and a lack of alertness, and oftentimes that's their first sign that they have a urine tract infection. Incontinence also leads to cellulitis and pressure ulcers, and most importantly, it's the most common reason for transfer of our older patients from an acute care setting where maybe they've fractured their hip or they've had a stroke to a long-term care institution. And this is where we, as allied health workers on the floor, in the hospitals, in the clinical situation, can really make the biggest impact. When we look at the 8 most common chronic conditions in our 65 and older population, we can see that urinary incontinence is right up there with diabetes, osteoporosis, and heart disease, except a lot of the time when our patients present to a primary care health practitioner, they will be told, oh, it's just a normal consequence of aging or a natural consequence of childbirth, and they tend to be ignored as it's not a life-threatening disorder. When we look at the prevalence of urinary incontinence, and this is all kinds of urinary incontinence in women by age group, we'll see an incremental increase with the dark bars going up. We'll see an incremental increase in the incidence of urinary incontinence until it peaks at about 45 to 54 years of age. Then we'll see a decline in numbers and an increase again at 75 to 84-year-old age group. And this is when you're going to see more of your functional disabilities and cognitive impairment problems. So assessment of your patients is vital because adequate assessment leads to accurate diagnosis and adequate treatment modalities. We haven't got it. Do you know why those slides keep flicking? Is there a reason they keep going forward, the slides? I'll keep going. Sorry about this. It just keeps flicking and going forward. So adequate assessment leads to accurate diagnosis and good treatment outcomes. So it makes for a happy patient and a happy healthcare provider. Having a working knowledge.
Turn this one out and you use just here.
Yep, lovely, thank you. Thank you. Having a working knowledge of the diagnosis and treatment of the different kinds of urinary incontinence is fundamental to your patient's care. Taking a thorough history, and we know this can be subjective, especially in our older adult population, where they have huge medical history and a great big, list of medications, and they often use it as a social visit. It can be rather exhaustive, but even though it is subjective, it really will help to elicit the most likely diagnosis of your patient's bladder problem. Using our listening skills, and as allied health workers, I don't need to preach that to any of you. We're very good at listening, we're very good at showing empathy and understanding, and we just have to remember that most of the time, most of these patients have waited at least 5 years or more before they even got up the gumption to visit us at the clinical level. And it's a very private, a very embarrassing topic to discuss, so we just need to have that in the back of our minds. It's important that we measure the degree of bother. I've had 84-year-olds that will leak urine every week, every day, and all they want from me is to teach them how to use a product, how to get some bladder training skills so they can get to bingo or get dancing once a week. And I've also had 20-something-year-olds that leak once a month in the gym when they do flapjacks, but it's very bothersome to them. So the degree of bother will determine for you how aggressive your treatment modality needs to be, and is very important. Taking in your urinalysis and letting your primary care physician know about the urinalysis if there's any positive findings. And I only culture the urine if there's positive findings in the urinalysis and the patient is symptomatic of a UTI, else we do not culture. And of course, never assume, and I always teach this to my students, but we've all assumed at one point in our career, I know I'm guilty of it, and we could just assume that this very healthy 94-year-old that can stretch like this and go for a mile-kilometer run in the morning is very healthy, but when we see her in bed, tucked up with her sheets and just fractured her hip in your hospital setting, she's going to look very weak. You might consider she has some functional disability, and you might consider that she has incontinence. So it's really important to ask your patient what their continence status was when you first meet them. So there are age-related changes that do predispose our older adult population to urinary incontinence. One is detrusor overactivity, and of course we see this in all ages, but more commonly seen in our older adult population. BPH, or benign prostatic hyperplasia, seen in our 50-year-old age group and up, and this will cause obstructive voiding symptoms as well as incomplete emptying and possibly overflowing continence. Atrophic vaginitis and urethritis, again more commonly seen in our post-menopausal women, and will often result in Lutz symptoms. Our older adult population tends to have a decreased ability to postpone voiding, and so it's normal to postpone for 15 minutes or more, but our older adults may only be able to postpone for up to 5 minutes. They have a decreased total bladder capacity. So normal bladder capacity would be 350 to 500. In our older adult population, it's more like 250 to 400. And this is because they have decreased detrusor contractility, and they tend to have an increased post-void residual. So I always say, don't be alarmed if you're doing an ultrasound and you see a post-void residual in one of your older patients of 50, 75, even sometimes up to 100 mils, because it's normal with your older adult populations and insignificant if it's not causing symptoms. So, when we look at the requirements of continence, you're going to think these are very rudimentary, and indeed they are. You don't need me here to tell you about the requirements of continence, but sometimes we forget about these requirements when we're at our patient's bedside. So our patients need to be aware of the urge to void. Well, of course they do. We all do. But if they have dementia, Alzheimer's, any decline in functional ability, cognitive dysfunction, then they're not going to understand their bladder signals and when they need to go visit the toilet, or in fact, where the toilet is. They need to get to the toilet when they need to, and of course they do. We all do. But if our patient is restrained, and this could be from sitting them on this side of the bed and putting their walker on the other side of the bed, we're still restraining the patient. They can't get to the toilet independently. They need to suppress the urge to void until they get help, until they reach the bathroom. So if they're in a hospital setting and they call the bell, if the nurse or a caregiver waits for too long, they're not going to get to the toilet in a timely fashion. They need to void, obviously, when they get to the toilet, involving sympathetic and parasympathetic nerve innervation, and I will go over those in a minute. And of course, they need the manual dexterity to be able to undo zips, buttons. They usually have layers and layers, our older patients, and they often have hip protectors. So just sometimes involving an OT and a physio will really help in this manner, so they can get to the toilet in a timely fashion and pull their knickers down so they don't have an incontinent episode. And they need the motivation to be dry, and this comes from all of us. So when we look at assessments, it's really, really important, and I think the girls are also going to cover this, to use validated tools such as the ICIQ, the King's Health Questionnaire. There's all kinds of validated tools out there. I do tend to use the ICIQ, which is the International Consultation on Incontinence Questionnaire. There's a female form, a male form. There's a nice short form that I tend to use for our older patients. And what's nice about it, there is one for fecal incontinence too. What's nice about it is it asks the question, for instance here, during the night, how many times do you get up to go to the bathroom on average? If you have that problem, you check it off, how many times you need to get up at night to void, and if this problem is bothersome. So it's measuring the degree of bother. Other very important assessment tools are your bladder diary, and there's a ton of research in the literature that shows evidence for 3 to 5 day bladder diaries. This will give us so much information. It tells us not just how frequently the patient is visiting the toilet, but it will also tell us about their functional bladder capacity, or how much they're voiding each time. It will give us an idea if they're voiding more in the morning, more during the night, more in the evening hours, and it will also give us an idea of when they're leaking. Have they got urgency on the way to the bathroom? Are they leaking on the way to the bathroom? Or are they leaking with different maneuvers, such as stress maneuvers? It's also really important to evaluate their bowel function. And I'm sure most of you are aware with the Bristol stool chart, I typically will do a 2-week bowel evaluation because we know constipation will affect the bladder in an adverse manner and reduce bladder capacity and cause irritability. Very common to have constipation in our older adult population. And so it's not just about how frequently they have their movements, but what the stool looks like. If they have these little bunny balls, as I would describe, it's a constipated stool. So they might tell you they've got 3 bowel movements a day, but we know they're still constipated. Type 4, soft, easy to pass without straining, is typically a normalized bowel movement. So continuing our assessment, we should do a post-void residual. Most of us have these wonderful bladder scanners in our units. We no longer have to do an intermittent cath. We need to do a history and a physical, which will include a pelvic examination. We should also take an intake of their fluid intake. This is not just how much they're drinking in a 24-hour period, but when are they doing their drinking? Are they coming to you complaining of nocturia, but doing all their drinking in the evening hours? Are they consuming water? Are they sipping, or are they bolus drinking? Are they drinking good fluids like water, or irritating fluids like caffeinated beverages, tea, coffee, and Coca-Cola? What's their functional ability like? And sometimes I can just assess this very briefly when I get them in my waiting room, see how they get up off the chair, see how they mobilize down my long corridor to my clinic room. Do they need a walker or assistance? Are they able to get on my bed, lie on the bed, and get up and down on a lower seat? And obviously need help with allied health workers, OT and physio, if they have physical disabilities. We need to take a thorough assessment of their medical, surgical, and obstetric history, and surgeries especially in the pelvic area, like radical prostatectomies, hysterectomy, previous bladder repairs, TBT surgeries, all significant in our assessment techniques. When we look at pad usage, typically we're not going to do pad weighing unless we're in a clinical trial setting, but typically what I will do to assess the degree of leaking is ask the patient what type of product they use, if they are using a product. Is it simply a light liner? This is a men's product here. Is it a full brief or a garment worn, or a product they put on their chair or their bedding? What is the degree of wetting? I usually ask them, is it damp, wet, or soaked, and how many times they change their product. And this is a way we can evaluate at the initial assessment and at the end of our program to see if hopefully we've got rid of the product, or if they're using less amounts of products or thinner, less absorbent products. I find many of my older adult patients will also tend to wear menstrual products because they're cheaper, so we really do need to educate our patients to use bladder products. And also they tend to save money by using wads of paper towel and toilet paper and sometimes even towels. So we need to identify contributing factors. The first three I have already covered. Fluid intake and caffeine intake I also covered. Excessive weight, especially in the abdominal area, has been shown to increase the incidence of stress incontinence. And in fact, one study showed there's 26% less likelihood of urinary incontinence if your patients are slim and active. Smokers, well, they tend to have a chronic cough, so they tend to present to you more with a chronic cough, and because of that, more stress incontinence. And it's not quite clear if the nicotine is an irritant to the bladder or not at this point. Previous pregnancies, parity, and mode of delivery is, of course, very important because they will impact on the pelvic floor. Underlying medical issues and medications such as diabetes, dementia, fractured hips, anything that causes functional disability, and medications both over-the-counter and prescription. Recurrent UTIs can often contribute to urinary incontinence, and sometimes incontinence is the first sign, the first symptom the patient will have of a UTI. And if there's environmental barriers to care, especially in the home care setting, a lot of our older adult patients tend to have clutter in their rooms, and they're getting up at night in a poorly lit room with lots of clutter. So sometimes bringing in OT, bringing in physiotherapists to improve their mobility, getting a heightened toilet seat, getting rid of the clutter will certainly help, and definitely to prevent falls. Getting a voiding history. Does the patient have a weak urinary stream? This might be obstructive voiding symptoms like BPH. Is it an intermittent or staccato stop-start kind of a void? Again, kind of obstructive voiding symptoms and straining to void. Do they have a feeling of incomplete emptying as they leave the toilet? Do they have a prolonged void, which again would show obstructive voiding? Do they have a post-void dribble? We can see this in our post-radical retropubic prostatectomies, as well as we can see it with our prolapse patients. Do they have hesitancy? Do they have to sit and wait 5 or 10 minutes before they can initiate their void? Do they have spraying? And do they sit to void? And especially with our women, do they hover? And so many times I have to tell my patients, you can't hover over the toilet, you have to sit, even if it's a public toilet. Do what you need to do, put toilet paper on the toilet seat, but sit, relax your pelvic floor, don't push to void, and let the bladder do its job. It's got a great functioning detrusor muscle. It can empty its bladder because we cannot relax our pelvic floor by hovering over the toilet. We need to ensure that when we do our assessment, we've diagnosed the type of incontinence. Is it stress incontinence, overactive bladder? Is it functional incontinence, obstructive outlet disease causing urinary retention and overflow, or neurogenic bladder with our diabetics and neurogenic spinal cord injury patients, multiple sclerosis patients that will result in overflow incontinence? So when you look at why your patients are incontinent, it's really important that you understand the mechanisms of continence, which can be quite intricate. There's three filling, storage, and evacuation. So there's 3 phases in the mechanism of continence, and all 3 phases need to be intact in order for continence to be maintained. During filling and storage, the detrusor muscle relaxes to allow bladder filling under innervation from the hypergastric nerve. At the same time, the hypergastric nerve helps to contract the internal sphincter at the level of the bladder neck so that all that urine can be contained. There's a secondary mechanism under innervation of the pudendal nerve at the level of the pelvic floor at the external urethral sphincter. So this allows filling and storage. Now, little stretch receptors in the bladder are sensitized to the feeling of a full bladder when our patients reach bladder capacity, 350, 500 or less amounts in our older adult population. And the signal is sent up to the higher centers of the brain, the pons and cerebral cortex, where the decision is made whether you need to evacuate your bladder. For me, I'm going to have to postpone. I'm going to have to run off the podium. For you, you may have to go imminently and take a visit to the toilet after that very strong coffee out there. Once the signal has been established, the message is sent back down to the S2, S4 region, to the pelvic nerve, which squeezes to empty the bladder via the detrusor muscle, via the pelvic nerve. The internal sphincter relaxes. The external sphincter relaxes at the level of the pelvic floor as long as you're sitting on the toilet, and complete emptying occurs. So sometimes I say it's easy to compartmentalize your patient's bladder problem. So with filling and storage, it would be an overactive detrusor muscle, so overactive bladder, urge incontinence, or perhaps a weakened pelvic floor at the level of the external sphincter. So that would be stress incontinence. That would be a filling and storage disorder. Whereas an evacuation disorder may be from a spinal cord injury patient or a neurogenic bladder with multiple sclerosis or Parkinson's, that they're unable to empty their bladder. So due to incomplete emptying, they have evacuation disorder, that they're having overflow incontinence. So it helps to compartmentalize. We need to assess atrophy, and especially with our older adult population, postmenopausal. The lower urinary tract is very estrogen dependent. There's estrogen receptors all along the lining of the urethra and the bladder lining. And after menopause, postmenopausal, you'll see those estrogen receptors deplete. So instead of this nice supple tissues and closing coaptation and a good blood supply, premenopausal, you're seeing these very atrophied, thin tissues that really have no closing mechanism available. So we do tend to see an increase in incontinence in our older population. We do need to assess for vaginal atrophy. Typically, we'll see a thinning of the tissues and a change in the color. We'll see this very white appearance, and there's agglutination both of the labia minora and sometimes of the labia majora, And also, we'll see the typical sign of estrogen deficiency is this urethral caruncle, which is this red erythematous kind of mass that exudes out of the urethral opening. We do need to do an assessment of the pelvic floor muscle, very important, and I will do an internal exam, both either vaginally or rectally, for my patients to assess both the strength of the pelvic floor contraction and the endurance of the pelvic floor contraction. And we tend to use the modified Oxford scale, a very simple, validated scale, 0 being cannot feel a contraction and 5 being I can feel a great contraction. Sometimes with our older adult population, it's very hard to do an internal exam. The tissues are so atrophied, it's very difficult without causing discomfort and pain. So sometimes we can just visualize a pelvic contraction by looking at the vulva area. So this is a relaxed state, and this is when we're doing pelvic floor contraction. You'll see anal retraction here, you'll see clitoral descent here, and a closure of the vulval vault. And sometimes it's an easy way to get around teaching pelvic floor exercise without doing an internal, or an internal is best. We also need to assess for pelvic organ prolapse. This is a grade 3 cystocele or a rectocele, and we can do this by an internal examination, and it would show endopelvic fascial support loss here. So when we look at diseases and disorders that are associated with urinary incontinence, we can see that actually most of these diseases and disorders are also associated with older age. So we wonder how any of our older adult populations can actually maintain continence. So in finishing, you're the ones that can make the difference. We as allied healthcare workers can make the difference. Always ask your patients, do they have symptoms of UI? Make sure you get their, were they continent before they present it to you. If you're in an acute care setting, such as a hospital, let them know that incontinence is not a natural consequence of childbirth, nor is it a normal part of aging. And make sure you you liaise with fellow professionals, nursing, physio, OTs, and if you're not comfortable, then refer on to a specialist and just let them know they're not alone.